Welcome to the Roetzel HealthLaw HotSpot. HealthLaw HotSpot is a podcast for physicians and health professionals that covers the legal issues and trends that affect the healthcare industry.
Hi, everyone. This is Ericka Adler of Roetzel and Anderson. Thank you for joining us for the HealthLaw HotSpot. Today, we're going to talk about value-based care, and I'm joined by my partner, David Hochman, shareholder at Roetzel and Andrus, part of our healthcare group, and also the partner in charge of our Chicago office. And our special guest today is Daniel Marino from Lumina Health Partners. Dan specializes in shaping strategic initiatives for healthcare organizations and senior healthcare leaders in areas that include population health management, clinical integration, physician alignment, and health information technology. Dan is a frequent speaker at healthcare industry conferences where he shares his insight into the shift to value-based care and trends in population health and data analytics. And I'm really excited to have Dan with us today. I've worked with his organization and him over the past, decade, let's say, right?
Mm-hmm.
And I know he's a real expert in this area. And so what we really wanted to talk about today is we hear so much about value-based care, but do we really understand what that actually is? And, maybe we could just start off by kind of explaining, what the basic definition is and how the average physician is really impacted or not impacted, I guess, by value-based care.
Great. Well, thanks, Ericka. David, good to see you all. Happy to be here. Value-based care is really the concept of changing the reimbursement structure to begin to get, let's say, reimbursed or compensated based on the quality of care that providers are providing to their patients. So, in the normal fee-for-service type of structure, physicians historically get paid for the number of patients that they see, right? A patient comes into their office and they charge a 99213 and they get a reimbursement for that. Value-based care actually adds additional revenue stream to it. So not only are they going to get paid for the patients that they see, but they're also going to get compensated for the quality of care that is being delivered.
Okay, so when we talk about quality, though, who's in a position to judge how good a doctor is? So, how are they being judged for their quality?
Yeah, that's a good question. And that's something that the industry has really been working through for a number of years. Quality is really broken down a couple of different ways. Quality could be structured around the performance and efficiencies around utilization. So, again, making sure that you're creating a situation maybe around your referrals that actually creates efficiency and helps the patient, let's say, instead of having certain rule outs, it's more aligned around what the patient actually needs. And you then begin to think about that clinical efficiencies as part of quality. The other piece of quality is actually looking and measuring, let's say, the lab output or what the effects have been on that particular patient related to their diagnosis. So I'll give you an example. Patients who have diabetes. A common indicator to measure the effects of diabetes is the A1C level. In the industry, an A1C level above, say, a 7.5 is considered high risk. So as a patient is seeing their physician, the physician will obviously treat the patient for their diabetes, but then to incorporate other things to help them bring down that A1C level. So after a period of time, if the A1C level goes from a 7.5 to, say, a 6.8, that would then allow you to think, well, the quality is definitely getting better. It's helping that individual. And then, it's helping that patient in its entirety. And you should then be able to get some type of reward for that, or at least be able to get some recognition for the work that's being done to help the patient improve around that service.
So I guess the patient population probably has an impact. And if you have a lot of you're the guy who gets all the hardest patients because you're so good at it, maybe this is patients can't be improved, or no matter what you do, you're not going to be able to earn those quality points. I mean, how do they take that into account? Is it more like it averages out? This was high quality by our measures, this wasn't, so you kind of in the middle?
Well, it's a good question. The data and the analytics around how you manage the care of population becomes really important. And you're right, there's some patients, if you look at a physician's population, they may have a more complex, what we would call a higher risk population. And the data would help to support that, right? So if it is considered a little bit more high risk, that actually works to the physician's benefit, because a lot of times if they're more complex, they end up having to see the patient, take a little more time with the patient. Well, in a straight fee-for-service type of a structure, if you've got a, say, a geriatric population that is quite complex, and you may only be seeing 2 patients an hour in a fee-for-service realm, that's going to affect your income. However, in a fee-for-value, if you're spending the time with the patient and you're actually seeing improvements in the quality outcomes of those patients, and that's layered on as an additional reimbursement, that actually helps the physicians, it helps the patients, it better aligns a lot of the systems and processes.
Do you get much feedback from physicians who see a high volume of patients and now are saying, well, I'm not going to be able to see as many patients, and therefore, how am I going to, where are the hours in the day coming from? Keep my the way it is.
Absolutely. What we often say when we work with physicians, it's a change in mindset going from fee-for-service to fee-for-value. And let's face it, in today's structure, the contracts that we have with payers, a vast majority of it, probably 85 to 90% of the revenue that we get is still fee-for-service based. That's not going away. So we have to continue to focus on volume, but we have to keep our eye on what I call the fee-for-value ball, because as we start to move, as the payers start to shift risk to providers, and they're doing it all over, as providers, they have to focus now on not just the number of patients that they see, but the care that's being delivered, and they have to start to measure that. So Ericka, as you were saying, where do you start to look at in terms of identifying the value that a physician is providing? It's around creating these efficiencies. It's around chronic disease management. So you have your top chronic diseases that really allow for improving, and that is in fact measurable. But it's also really creating efficiencies around referrals, around follow-up, around care management activities, those type of things. That's what really drives a lot of the outcome and helps, David, as you said, kind of move past just focusing on volume, but focusing on value.
I think that's probably a hard transition for some older doctors to make. They're used to how things work. I see this many patients. This is what my revenue is. This is what my RVUs are. And now, you're telling me that unless I do X, Y, Z, I'm not going to hit that target anymore. And I think that can be kind of a hard shift. Some of the younger doctors coming out, their contracts initially already have built in measurements for quality. So for them, they won't know any other way. A lot of contracts I'm seeing will show you can earn up to an extra 6% of your base salary for meeting certain quality measures, or other types of factors like that. Are you mostly seeing the quality measures as part of physicians' actual compensation, or are you still seeing it as kind of an add-on? So they have like their base, whether it's collections, RVU, salary, whatever, and then they can earn extra money for value. Like, how are you seeing that really being done?
It really depends upon what the managed care contracts look like and how they're starting to evolve to more fee for value with performance-based components in it versus fee for service. The fact of the matter is, we've talked about, the payers are wanting to now shift that risk to the providers. The payers are not offering these large increases in fee-for-service reimbursement anymore. You're lucky if you're getting 1 or 2% as a cost of living increase. So if you really want to make up that additional revenue stream, you have to focus on your performance, on your outcomes, and the payers will pay for that because it helps them. So as your contracts start to take on a larger percentage of value, the compensation also has to then evolve to a larger percentage of value. If you've got a contract that has, let's say, 10% or even 15% of your reimbursement tied to some type of value or performance, yet your compensation for your employed physicians is 95% RVU based, you're not going to be aligned, right? You're just not, because the physicians are going to be focusing on, again, seeing the number of patients, which will actually detract from the opportunities you would have on the value-based care contracting side. So we do have to see that alignment. And one last comment that I'll make a mention to, as physicians get involved and they really start to understand and can start to measure and quantify the quality of care they deliver, they actually really enjoy that. They appreciate it. And, years ago, this early on in my career, when we were working with a health system on clinical integration, there was a physician that I was working with, and he was adamantly against us being able to measure the quality. He thought we were going to be using it against him and so forth. So it took a little bit of work. As we started to get in 3, 4, 5 months after the fact, we started to compare his practice, and he was primary care, against other primary care practices. And all of a sudden the light bulbs went on. And he made a comment to me, and something I'll never forget to this day. He said, Dan, I always thought I was a good doctor, but it wasn't until we actually started to see these reports that it actually led me to believe, or helped me understand, where I was a good doctor and where I needed to improve. Yeah. So physicians really do enjoy that if it's presented the right way and if you can align those incentives.
Then I've seen in hospital contracts, hospital-based group contracts, it's not unusual if a hospital providing some financial support to have a dashboard of quality metrics that the group has to meet to get all or part of that stipend that they're providing. How does a doctor in private practice come up with that list of criteria? That's the thing he should be looking to develop.
Yeah, a doctor in private practice is certainly at a little bit of a disadvantage if they're negotiating totally on their own, because they're going to be dictated to from the payors what they should be measuring. And unfortunately, the payors do not have access to true quality measures. They have access to performance measures. So the physician in private practice is going to be held accountable to HEDIS measures, which are claims-based measures, which doesn't really show quality. It shows utilization management. But if that's all the private practice physician has, they could still do very well in that as they migrate to more quality. What we advise a lot of the private practice physicians is to start to align with some ACO, some clinically integrated network, where they can take advantage of the larger network structure while still maintaining their own independence and their own autonomy. Plus, they have the ability to incorporate a lot of the capabilities that are going to be necessary to succeed in value-based care that they won't be able to do on their own.
Right. I mean, to me, that's essential. I can't imagine with all the resources that hospitals have, they're able, and I don't even think most of them have necessarily updated their contracts the way they need to be, but for a small group that can barely, afford to keep going as they are, to have to figure out how to redo their contracts or how to redo them. An ACO would be really valuable. Most of my groups that are participating in ACOs, they do see tremendous bonus payments coming out of it. So I think more and more groups are starting to really see the value of participation from a monetary standpoint. And like anybody else, I mean, money talks, right? So yes. if it's not going to cost you money, or it's going to cost you some money but make you more money down the road, I think that probably is a great way to sell it. Although I think knowing that you have areas to improve in, what might be a motivation for many as well, right? So that's something I think is really going to be interesting for our clients to hear. David and we do a lot of contracts, and I really can't say that with our private contracts that I am seeing a lot of ACO participation, but I'm definitely not seeing modifications to the standard compensation approaches. I haven't really seen that difference at all. I can say that every single institutional contract I look at pretty much does have, that quality piece built in. And I find it interesting because the quality piece is always tied to like somehow having to stay for like the whole year. How often are these quality bonuses or these benefits available? Is it really, you have to stay that whole year, or are they just pocketing that money if the doctor leaves?
Well, it depends upon what the contracts look like. In most value-based contracts that you negotiate with the payors, they have annual true-ups, annual reconciliations. And in some cases, by the time you end up reconciling it, you may be 14, 15 months, after the initial contract period to reconcile. So you do have to wait a period of time. Now, David, to your point, you're absolutely right. What will end up happening, so the hospital realizes, well, physicians are doing all the work, right? We don't want them to necessarily wait. What a lot of hospitals will do that participate in clinically integrated networks is they will front load the potential savings opportunity and provide for some level of a quarterly or semi-annual payout with then a reconciliation that would occur at the end. But again, you're modeling, you want to make sure that you never want to take money back, right? If you're going to give it, you want to give a little bit and hopefully give a little bit more later. So you do want to make sure that the modeling is correct. But I agree with you, Ericka. It's really not fair for the physicians who are doing all the work to have to wait for a year or 15 months, because frankly, this is part of their income.
Their package,
Once you get into a structure, the revenues does start to come in on a regular, or the incentive payments, let's say, come in on a regular basis.
Right. I think hospitals, a lot of them are using this just as a source of greater revenue. Maybe it'll offset some of the issues with the new fee schedule, which the topic for today. A lot of times also I'm seeing contracts where you can get the value money, but only if you hit certain production targets too. So I feel like there's almost like a mixed message, like you're doing everything right on the value front, but oh, by the way, if you didn't do enough volume wise, we're not giving you that money. So I also feel like, that quality message is not being made as clear as it should be.
Well, it's still the balance, right? We call it, a foot in both canoes, right? It's the balance between the fee-for-service reimbursement, of which the hospitals are still getting reimbursed pretty well, versus the shift to value. And, what we tell our clients, you can't move too fast and you can't move too slow. You have to figure out where that balance has occurred, and you have to look out on the horizon 2 or 3 years as to not just what this contract looks like with your payer, but what is the next contract potentially going to look like, and that's what you work towards. But it's a culture shift, it's an operational shift, it's a financial shift, that all those things have to be taken into consideration.
Right.
Yeah, it's interesting. I'm thinking about my clients that have some value-based. I have a few clients, they have a base salary, and then there's a chunk of the compensation pool that's based on factors to be determined. And that is typically groups where there is a small group of owners, or there's one owner. So you're not having to go and try and herd cats to get everybody to agree upon what the criteria are.
Yeah.
But sort of this benevolent dictatorship works better in implementing that type of model where you don't have the rules set in advance. And private practices who don't have all the resources to go and figure some of these things out, it gives them the ability to go and shape providers' performance sort of on the fly.
Yeah, well, a lot of times we do a lot of work with building ACOs, building clinically integrated networks, that sort of thing. And within a lot of the networks, you'll have the employee groups, but then you have the independents. And the goal is, to integrate the independents because they want to stay independent, right? And the CIN should really support that. So a lot of times what we'll do is when we structure the incentive reimbursement models, we will advise, we'll give the monies to the practice. We'll provide some, let's say, advisory support on how we think it should be distributed. But at the end of the day, it's really the owner's discretion as to how they want to do it, because there's other things that are going on in the practice that as a CIN, you may not be aware of, and you shouldn't, right? Give it to the practice, let the practice be responsible for it. As long as the practice performs, that's the most important thing.
Right. Well, so one of the topics we were talking about before we got started today was, COVID, the most popular topic out there. How has value-based care been impacted by COVID, if at all?
It's actually impacted a lot. If COVID did one positive thing, it exposed the limitations of fee-for-service. Thinking back with all of the decrease in elective procedures, it hurt, primary care, but primary care recovered a little bit because of some of the virtual care models and telehealth that came to be, but it really hurt the specialists, and in particular the surgeons. And if the physicians were involved in a value-based care model where they still could treat the patient and get reimbursed for services outside of just the procedures, they wouldn't have been hurt as bad. But because many of the surgeons and many of the contracts we have today, they're, as we've talked about, they're predominantly fee for service. If they didn't see the patient, they didn't get paid. So so what we're starting to see now is, out of that lesson learned, are new ways to structure these contracts and a little bit more focus on the quality, the oversight, the integration, the relationship build with patients, the access model with patients that are above and beyond just straight fee for service. And we're seeing those wrapped into these fee for value contracts. And frankly, I think it's a great thing for the industry because it's really helping us to better align with the needs of the patients.
Well, I think, yeah, I mean, COVID definitely, from our perspective, our doctors that are paid based on production or paid based on RVUs, they truly suffered the most during that period. Yep. And I guess I really hadn't thought about, the impact on value-based care as it related to that COVID topic. So I think that's kind of interesting. So what do you see then happening, going forward? I know you mentioned you recommend that independents talk to ACOs, join ACOs. Are you seeing that as a growing trend, or we kind of hit the limit on that, or are they going to get bigger, stronger? What do you see happening?
I'm seeing, we're seeing a lot more what we call these strategic partnership discussions that are occurring, from hospital to hospital, physician to hospital, physician to physician, for instance. I think folks have realized, obviously COVID hit folks hard in 2020 with their incomes, and they're trying to figure out how to do it differently and how to leverage a little bit more servicing. So we're seeing a lot more of these strategic partnership discussions occurring. In some cases, we are seeing, still the trend of independents going and wanting to be employed. We are seeing that because, again, physician can't go through what they went through before. They don't have the balance sheet to recover again in the event that something was to happen. But we're also seeing many hospitals saying we need to reach out and really help our independent providers. And so we're seeing them extend certain services, welcome them into their ACO, provide some support and some services to make sure that they can succeed in there. So we think that's only going to continue. I think the other thing that we're starting to see too is these new care models based on virtual or remote care. Physicians have to really start incorporating that into their practice. Although I think patients still like the one-on-one personal contact of seeing the patient, we also have seen convenience-based care really taking off. If patients need something, they're calling the ZocDocs of the world or their telehealth provider of the world, and they're getting immediate access to primary care. That has to be incorporated into the care model. So we're seeing the care model starting to evolve a little bit more, and will continue to evolve in this next year.
Kind of on a related topic, and I guess this wasn't really something I thought about right now, but until right now, was, we're handling a lot of transactions right now. We're super busy. I don't know what it is about 2021. We have some hospitals acquiring practices for sure, but the majority of these transactions really seem to be private equity. And so I guess I'm kind of curious, is private equity, I haven't seen any of them build into their models anything related to quality care at all. And, some of these practices do participate in Medicare, right? And I guess I'm just kind of curious what your thoughts are. Like, how does private equity, as in rather than an independent, rather than a hospital, how do they fit into this picture?
Well, private equity is starting to put, they started this before COVID, and I think they're ramping up. They're putting a lot of their dollars into these alternative provider organizations that I would call them. So, what you're starting to see are these more focused primary care models that are focused on convenience and that are tying in health plans. So, for instance, Oscar Health is one example, right? So they've put in a lot of private equity dollars. That's going to be released as a initial public offering very soon. And it's going to change that primary care model for a lot of the markets. We're seeing private equity going into a lot of these telehealth and virtual care and digital health platforms as a way of being able to promote it and support and the new access model, if you will. We're also seeing a lot of private equity dollars going into these new contracting vehicles, a lot around direct to employer type of contracting, but helping these networks expand into the health plan space without actually creating their own provider sponsored health plans. So it's interesting to see where the money is flowing, but those, at least off the top of my head, those are some of the big three areas.
So, I mean, the trend overall then, whether hospital, independent, or private equity, is everybody cares about the outcomes going forward. And
absolutely.
no going back from this point, right?
Yeah, absolutely. And if anything, it's, private equity and where they're putting their money is providing a little bit of unwanted, unneeded, in some cases, competition for some of the hospitals and the physicians. But they're seizing on that opportunity around convenience, around virtual care and that sort of thing. But it is all tied to outcomes. It's all tied to clinical performance, or it's tied to convenience and patient satisfaction.
That's great.
Well, it'll be interesting to see if these private equity firms are in here for the long haul, or whether this is going to be a more typical private equity that in 3 to 5 years are going to want to sell to somebody else for more money.
Yeah.
Go on to the next big thing.
Yeah, I think that's probably going to be it. They turn it over, and it's still, I sort of put it under the umbrella of these population health service organizations. So I think they'll probably end up building components of that, whether it's telehealth or analytics or these health plans, and then sell it to somebody else. And then you're going to get these super private equity companies, which will have maybe 4 or 5 or 6 different lines of business that will be all grown from these private equity things. We're starting to see a little bit of that now.
Yep.
Right. That's really interesting. All right. Well, I think what we're going to do is we're going to wrap up this topic. So do you have any final thoughts you want to share with us?
Well, I think, support to providers, they're the core of the healthcare delivery system. And I guess my advice to a lot of the physicians, particularly the independent physicians, is, begin to think about what are those important things to your practice, how you can continue to provide the care that you want to provide to the patients in your community. And don't be afraid to have conversations around how to best leverage yourself within a partnership model. And it doesn't have to be employed, but at least to be able to think about how you can do more with less and how you can continue to position yourselves for success in your community.
I think that's great advice, and hopefully our listeners today will enjoy it. So thank you so much for joining the HealthLaw HotSpot, and we hope to see you back here next time. And special thanks to Dan for joining us today.
Thank you both. I enjoyed the conversation. Take care.
Thank you.
Thank you so much.
Use of the Roetzel HealthLaw HotSpot does not create an attorney-client relationship between you and the firm or any of its attorneys. The Roetzel HealthLaw HotSpot should not be used as a substitute for competent legal advice, and you should contact an attorney in your state about any legal needs or questions you may have.